Dr. Banerjee to please hand over a bouquet of appreciation to our honored guest, Dr. S. D. Munana. Please, a round of applause. And I'd also like to call upon Dr. Kumar next. Our chair for this session will be Dr. Banerjee, who is the Professor of Department of Pharmacology at SSR Medical College. Please, a round of applause. And our second chair is Dr. Sashir Gokul, Professor and Head of Department of Microbiology, Manipur College of Medical Science.
We are honored to have you with us. Your remarkable contributions as a cardiac surgeon and your leadership as the director of cardiac services at the Cardiac Center in Mauritius have made a significant impact on cardiac care in both Mauritius and across the Indian community. Your pioneering work, including the first open heart surgeries in Madagascar and Botswana, along with your involvement in various esteemed scientific societies, exemplifies your dedication to advancing cardiac health. Now, we would like to invite Dr. Dillon to come forward as he will be sharing his views on revolutionizing health, the impact of AI ECG in the island of Mauritius.
But we all know that the specificity and sensitivity of the skin is not that basic. And it will roughly around 40-45%. Which means that when someone is doing a disease, he can tell you that there is a heart disease only in 40% of cases. Not that it's not occur, but because the system itself, it has got many flows, many drawbacks. ECG is a 100-year-old instrument that we have been, that we are still using. And it is not that accurate. And many times we are working the island. One patient goes to a medical clinic, he has got an ECG done, then the doctor can see everything is fine. He comes back home, and a few hours later, he has got a leak. This is the story we have told so many times in the island. So this is a real issue, and because in these many clinics, in these mobile clinics, we don't have specialists, we have medical ROs, and so we are going to find a solution. We are going to find a solution that is very easy, which is non-invasive, which is reliable, which improves the results better than the ECG, and which can be easily available within primary setup. This is where we have found this artificial intelligence that we work now with cardiography, a very valuable and reliable solution. This was the first publication in 2019 by the Germans and by the practitioners, by the specialists in the USA. And they start talking about the myocardial ischemia using artificial intelligence. Then, since that time, there have been many publications that you can see here. They are especially from Germany, but also in the European Society of Cardiology. There was a paper that was presented in 2023. And then even in the American Heart Association in 2023, there were sessions talking about this particular. But in the meantime, during the COVID period, I was already in contact with these German people, and I learned a lot from them, and we started introducing this artificial intelligence. We had our first machine in 2021, and we started using it, not at a very large level, but we wanted to learn more about it. In the meantime, all these publications have been done, and it's very quick, very rapid, so many big publications being done. The last one you can see are given by the NHS, and it was in August 2024, and I'm going to try to show you the results. This is the NHS results, and you can see the demographics. You can see what is very interesting here is that you have got a predictive value of about 80%, possibly 50%, a negative predictive value of 9.4%. So the sensitivity of some patient will be especially of 94%. So for 40-45, look, we are going at very, very high levels. And this is user friendly. It is readily available in the primary system, and we can easily replace the normal ECG. This is what we have done. This is an in the NHS study. This was the usual pathway of the patient with chest pain. There was no cardiography at that time, but now they have introduced cardiography at all levels. Why? Because they want to reduce the amount of referrals to the hospital. They have got very high volumes. They have got their hospitals which are very saturated. So, and even they want to be at pharmacy level. So they want to do this cardiography at pharmacy level. The patient with chest pain will do a cardiography, and if this cardiography is completely negative, there is no need to be referred to the NHS. There is another study that has been done in Brazil, in Sao Paulo study, and we look approximately at more or less the same results, much higher than the ECG. So we have introduced, this is a summary when we compare cardiography with using artificial intelligence, we have got a very high sensitivity. So this really affected us, and we say we have got to introduce it to Mauritius. But first, let us understand how it works. Why is it that we have got such good results? This Institute is going to show signs of schema when there is tissue damage. See, when there is tissue damage, but the cardiography is going to see signs of schema at the earlier stage, at the level of repolarization and depolarization at the cellular level. And this is the big advantage of cardiology. How can you do that? We are going to show you this. So here we are working with depolarization and it comes at an earlier stage and we can detect sleep. What I see is that we are having now, I'm trying to explain to you what is the difference between the classical electrocardiogram and the cardiography. The classical electrocardiogram uses a 12 ECG. We all know it uses 10 electrodes, and it is going to plot the potential difference in an XY direction. In a B dimension, I'll show you a bit more in the other slides. Whereas the cardiography is going to have the potential difference in 3 dimensions, X, Y, and Z. And the cardiography can also be moved 5D, 3-dimension, electrocardiogram using artificial intelligence. In this cardiography, this is the conventional ECG that we are going to use, and we are going to see the difference in potential between X and Y only. And in the electrocardiogram, we are going to put an electrode at the back of the patient, and we are going to see the potential difference in X, Y, Z. In the normal ECG, we lose all the electrical activities which put us back of the patient. In the cardiography, we put an electrode at the top of the patient. We know that the heart is fair, and that the electrical activity goes into 3 dimensions, X, Y, Z. In an ECG, we are going to have only the results in X, Y. I don't know whether you remember when we were doing cardiology, our children tell us, we must take the heart, you press it on the table, and it becomes flat, and this is what we do in ECG. We lose all the information which goes down. In this electrocardiogram, we are going to do the electrode, and we are going to also to see. So, what is happening at the back of the brain? Here, you will have the normal ECG with contraction here, and here you will have the cardiography, the representation of the electrical activity of the heart in 3 dimensions. Here it is in 2 dimensions, here it is in 3 dimensions. So you will have, we just see the 2 wave, and then this one is the forward wave, and then we have the 2 wave which is going up here. So this is a 3-dimensional representation of the electrical activity of the heart by putting an electrode at the back of the patient. From this, we are coming to an anatomy in 3 dimensions. So, and then we will analyze the heart in the frontal, sagittal, and horizontal view, and we are going to get more information on the classic XY electrocardiogram. And we are going to get results of So we are going to get results like this, and I'm going to give you all these results in the frontal, sagittal, and horizontal. But you will accept with me that reading this a cardiography performs a three-dimensional scan of the heart. It is going to use artificial intelligence to give a diagnosis. The P wave, the QS wave, and the waves become prompts, and it uses algorithm to give a result. Now, this is how it happens in practice. You have got this cardiograph, which is a small box. It is connected to the patient with 5 electrodes, 4 in front and 1 in the back. Whereas the classic ECG remember there were 10 electrodes. Here there will be 5 electrodes. It is connected to a laptop with the cardiac web application, and this one goes there either by wires or by Bluetooth. And then through internet it goes to a cloud which is situated in Frankfurt in Germany. It gets analyzed in the cloud and the results come back again. The whole process takes 12 minutes. So we have got the electrodes. We must learn how to do these electrodes. 1, 2, 3, 4, and 1 at the back. And we are going to record the electrical activity of the heart for 4 minutes. Which means that if your heart is beating at 60 per minute, we are going to do our analysis on 240 minutes. So this is another big advantage. 240 contractions of the heart are going to be analyzed by artificial intelligence. And then this takes 5 to 8 minutes to go to the cloud and to come back, and we get the results after approximately 20 minutes. So the 3 big advantages. One is that we are going to make a 3-dimensional scanning of the heart. Second, we are going to analyze 240 contractions. And third, we are going to use artificial intelligence. That's why we can get a sensitivity, a positive predictive value much higher than the routine ECG. And this is the report that we will get after 12 minutes. In any case, we will get a normal 12-minute ECG, so we can analyze this 12-minute ECG with all the parameters of the ECG that we are used to. Then we will get the vectorcardiogram, the heart in horizontal, sagittal, and frontal plane, and you get the parameters that you can see here. And the CSU index, the vectors, the angle, the superposition, the position, and the scattering of the fluorescence. So these are the new parameters which we are not used to, but I'll just go through in a few minutes. And we also get the rhythm analysis. We accept 10% contractions which are not normal. So for 240 contractions, it must be less than 10%. If it is more than 10%, then there is a problem with the result. This is what we use the bureau for atrial fibrillation, not the Mauritius. In Mauritius, we are really concerned with this data. And this is the final result. It gives you a summary. P being function, S is structure, A is rhythm. If everything is okay, then there is no problem. You can take the patient safely with 95% certitude. You can go, there is no problem. But if this P factor comes towards the right, then there is a problem with the function. So even a nurse, even a pharmacist, they are going to do. So it's very easy. If it's green there, you can very safely tell the patient, look, your chest pain is not related to the heart. We can relax it. But if it comes towards the right, then we will refer to this secondary care. We are going to take these parameters that are new to us. The first one is the CSG index that we can see here. Normally, this CLK index should be less than minus 0.27. And this one uses artificial intelligence to get that data, and it uses 290 different parameters in each heartbeat. So if you have a 250 heartbeat, you can include how many parameters is going to use. The cutoff value is minus 0.7, and if it is more than minus 0.27, it means that it is a test positive for the disease condition. But it doesn't necessarily mean that the disease condition is due to adenoma. It can also be due to anemia. So we are going to be very careful. That is analyzed by Dr. Medical. This index, if in Mauritius in our setup, if this index is positive, when we refer to the cardiologist, and then the cardiologist will examine and we see whether the patient should is going to have an angiography. And then this QS vector, a change in position in the QS vector to what the normal value is here, is in favor of a problem in the depolarization. And a change in the vector, it is repolarization. So we are going to analyze these results also. Then this one is the angle. This angle, this is a very, very long time. It is a very strong and independent predictor of cardiac. We can see when there is a hereditary factors, when in the family there have been more sensitivity to cardiac disease. This supervision, normally in a normal heart, the people should be inside the QRS. And we have the supervision must be more than 50. So if the supervision is not less than 50%, often correlates with conflict disorders and should be evaluated annually. Because if the people is on this side, it means that there is a problem with the profession. And this is the scattering. Here you've got 240 dots because there are 240 contractions. So the red dots, all the regions must be together. Just like this one, you've got red dot here, red dot here. Normally there has been an infarct. This is the situation we show there is an infarct. This one, it means that there is a problem with the revascularization. There is an ischemic disorder going around. And the magnitude also should be more than 4. Look at this one. A decrease in T-wave magnitude is often associated with an increase in T-wave scatter. If you put these two connect in the representation, decrease in T magnitude, increase in T-wave scatter, CLG index is positive, 100% constitution is standing up. So this is the study that we did at the Cardiac Center from January 2024 to 2024. We wanted to show that this cardiography is better than this stress test. And we had 1,776 antibiotics during that period. You can see the male, female, image, and then the number of cardiography positive which was referred for antibiotics. You can see here for the number of stress tests positive referred for antibiotics here, and we have calculated the positive relative values of cardiography is 6.1%, and that of stress test is 50%. So stress test is compulsory. In a screening program, you can't ask the patient to do the stress test. The patient is coming for screening. You want to have something which is handy. And this cardiography is handy. For stress test, you have to refer the patient to the hospital to do the stress test. But even then, the result for the cardiography is better than that of the stress test. So my conclusion, our conclusion, cardiography is as good as stress test. I'm talking about our context. I'm not talking about nuclear medicine and this type of complicated things. Simple things that we use on a country. We feel that cardiography is as good as stress test and can be done in the of stress test. Now, the stress test is going to be secondary to this is what I'm doing. And the cardiography is going to be primary. Here we have got walking patient. patients that are walking won't be screening. Here, the patient that is referred by cardiologists, you feel there's a problem. There's already, the recruitment is not the same. But in spite of this cardiography has shown better results than the stresses. I'll show you two examples that you can see. So this is a middle of 40. You can see all these parameters here. This is most normal. Cardiography was positive. So why is it positive? You can see that the CSV is positive. You can see the temperature is positive. You can see the angle is positive. Scatter is normal. So we did an angiography for this patient, and so you can see that there is an LED level here, which was scanning. This is exactly to go to this is the if we have detected this LED level in the screening program, this patient would have come with us with an infra in the LED meter, and you would have lost all these pieces. We want to detect the lesions before the 90% that I told in the beginning of the presentation. We want to reduce it. We want patients to be held in the treatment before they do an infarct. I'll show you another case. This is a male 48, and there is no symptoms, but there is a strong family history. We realize, okay, he is very physically active, and this is being positive for ischemic heart disease. Why positive for ischemic heart disease? You can see that the CSV index is positive, the T-wave is less than minus, less than 0.4, and the angle is basically strongly looking. And here you can see scapulotomy. See, you've got T here, there is scapulotomy. So, scapulotomy, T magnitude 2, CSV index positive, 100% we will see something. What did we see? This one had, so here, this is the component I was talking about. So this P factor is completely on the right, PS factor is in the middle, and A factor is on the middle. But P factor is on the right, we must refer to secondary care, and in secondary care, we did a heart scan, and we saw a 50% LED lesion. So 50% LED lesion on the heart scan, what do we do? We will put the patient on aspirin, we will correct his cholesterol level, we will get oxygen, we will be more careful, and so on, and we will continue for it. If it becomes more than 50%, then we will do an angiography, and if we need to do this, we will do this. So this is exactly what we want to do in the ILAC. We want to detect these disease before the patient gets an infarct. So this, my conclusion will be, it's a 5-week, 3-dimension VCT using artificial intelligence, and it is going to be simple question, you don't have to have it bad or what you time, and you will have enough experience, immense impact of the analytical of in our country, and I'm sure in other countries that in Germany, we find and we can do the primary setup. And then we can prioritize our effort to the secondary or tertiary setup. And actually, we can give patients to go to hospitals for nothing, and detection of ischemic heart disease before they come. I thank you for your attention. It was yes. Thank you very much, sir. Any questions from the audience? Yes.
Cardiologistry, and is there any reason why there's not much evidence in terms of tachycardia or any heart
Germans use it a lot because their population is an old population. They have a lot of age and they want to detect the population before it happens, before there is an illness. So this is a big issue to go. In our place, we have got young patients, and for some reason or the other, if your population is not that long, we often by ourselves in Europe or our hospital in Europe, all our population will go down, or at least 3 weeks, because the resilience of the population is very high. In Mauritius, this can participate exceptionally in the program. So is it really related in young patients? Yes, in the patients. I think there is something to do with Asian people here knows the music. I think that's what's happening.
I want to know that our ECG, when you are suspecting the right ventricular infarction, we do all the leads we use to keep right side of the chest. But you told that we are keeping the lead in the back side. You know that's right ventricular, just the retroexternal lead situated. Then how you will diagnose the right ventricular infarction in this cardiosonography?
In any case, we have got a normal that we are doing ECG.
Now 12 lead ECG, then the scintigram which is available in the primary set, 12 lead ECG in the other. That is easy way you are saying that. Or everyone you first do the 12 lead, then you will go for the that's it.
We will directly to the hospital. We have got the 12 ECG. This is the first results. And then we get the analysis of the therapy. So the doctor, let's say it comes red. It comes red, we refer to the second day. The second day is the CBC. And we see only the answer that because it's a question of who did it down on this way. This is the protest in Israel to bring it's not as simple as that. It might be a good
Last question, that's the arterial fibrillation. You are saying the very rare that it is the how will they know that that's arterial fibrillation go if the very young people also paroxysmal arterial fibrillation. Anytime it happen, anytime that CBA also can take place. That's why how that is also equally important for the detection of arterial fibrillation arrhythmia, like very common arrhythmia that is arterial fibrillation everywhere around the world. Thank you, sir, and congratulations for you that this is very new and very important thing you have delivered in your lecture. Thank you so much.
Thank you, Doctor. Now, please join me in welcoming Dr. Israel Junior Moses. Dr. Moses is a distinguished clinical pathologist and cardiology fellow with extensive experience in evidence-based medicine and cardiovascular research. Today, share his insights on the role of antenatal ultrasound in the detection of radio and post-station malformations. Please, let's give it a warm welcome.
Well, for those medical students, who of you, so which one of you are kind of lost, you feel lost in terms of selecting medical specialty in your life? Are we all concerned? We have it? Can you hear me? Yes. So you all have your specialty in your life. So raise your hand. Well, I'm just starting this so you can get knowledge in a sense that you're not alone. And I was part of that. Before I was assigned to cardiology, I was really lost. I did clinical pathology, I hated it. And then I was like, well, I need to select something in my life. But turns out that the biggest passion in my life was really research. And as a researcher, I can do and I explore any medical specialty I really want. And that's why I'm bringing this discussion, because I'm not a enrolling specialist or a gynecologist. I'm actually cardiologist, but I'm working with hematology and obstetrics. So don't lose your expectations, don't lose your trust. You're gonna find yourself in medicine. Well, if you're not, you just go and study law or something. Or my tenure, which was really my life. But anyway, so I'm going to talk about one of my colleagues' project. She called me one day and she was like, well, I'm really trying to get this performance, the performance of antenatal ultrasound understood. And then we reach out to certain points that, okay, let's try to understand what is the effectiveness of the ultrasound of the exam and the associated detection rates of cranial or facial malformations in fetus, and then we created this scoping review. So this scoping review was published last month. Well, this month, wasn't it? Yeah, this month. Last month, a few days ago, we published this in a very good journal that I'm currently leading, and this is the presentation I'm going to give. So basically introducing you, antenatal ultrasound has shifted medicine in a very positive direction. The detection rates associated with the exam per se are very high for several number of parameters and diseases that we commonly face in medicine and in obstetrics. But the 12 parameters that are standardized and prioritized by ultrasonographers are not the only ones that deserve the proper attention. And that's where our project really comes to the surface, because we know, based on Dr. Suma's, for example, experience with ultrasound, that the exam can really detect so many other different types of diseases and malformations in the intrauterine life stage. So and then it's a pretty fertile ground to make plans for us. So many random and spread evidence has been collected over years in terms of understanding the potential of the exam. But this is the problem with medicine at the time. We have so much evidence coming from so many different places, so many different scenarios, and somebody needs to collate this information, and that's my part, that's my job. I'm a big synthesis researcher, and this is the main reason why we created this project. So the main objective of this research was to evaluate and compile available evidence from primary studies regarding the applicability of antenatal ultrasound to detect neonatal oral malformation and their perspective, long-term impact improves health. And all this at the same time, we try to assess infection rates, the ongoing and existing challenges that healthcare providers they have with the routine utilization of exam and associated with performance metrics. Last year, well, not last year, this data, this data regards to the time that they the protocol on the Prospero. But this project was primarily published in Prospero by 2022. And we were trying to collect data from different databases. For example, for this one, we used Web of Science, Program, and Bayes and Cochrane. The inclusion criteria were basically the inclusion of any type of clinical trials reporting the detection of craniofacial abnormalities, identified through prenatal ultrasound. And we only selected those studies which reported at least 345 patients. We did some sample size estimates, and according to our calculation, that was the minimum amount of patients that we should observe those potentially those eligible studies. As an additional eligibility criteria, we have that we would include those reports stating and stressing the detection of any type of craniofacial abnormalities through 2D, 3D, or 4D dimensional scans. And of course, they would enroll patients and women from all the different stages of gestation. As we do review here, before I wrote this morning, before class, I get confused with all of those terminologies. I prefer to say multidisciplinary from now on, because I don't want to be embarrassed. We did work partnering with educational programming to really support us with the highest identification of potential studies. And screening, of course, was performed independently by two researchers who performed data extraction, which in this case, we decided to perform a narrative summary of the evidence instead of performing a meta-analysis. And I'm going to ask a question, and I have a gift for those who can explain me why it doesn't do that. So as far as our results concerned, we, after the implementation of those eligibility criteria, we ended up including 51 studies. So we ended up performing our data extraction, and then the data extraction yield approximately 600,000 pregnancies and over 680,000 fetuses in the life of our study. So far, the most common detected abnormalities were related to facial plaques, either both-sided or one-sided, and palate deformities. Sensitivity rates, they range from 65% to 100% of detection rates. And so which means that there's a huge variety of the performance of the specific method. So we observed that a few papers reported that potentially factors influencing the detection of these abnormalities. And it turns out that imaging quality potentially related to the infrastructure of either the equipment that the healthcare provider was utilizing during the time of the study, the gestational age, and the operator expertise, the ultrasonographer's expertise and experience with the machine was actually modified as well. Most important, so scans, they were mostly performed before 24 weeks, the first and the second trimester. And as I said, facial plaques, and importantly, facial plaques, they had that. I'm going to explore a little bit more about that. But of course, as you can see here, there was a different variety that they were potentially associated, they were potentially reported within those primary studies that were included in our analysis. But most importantly, as I said, cleft either left-sided or both-sided in the general abnormalities in the clefts were related and reported among those studies. Importantly, somebody, I don't remember who, talked with me about pregnancy termination, about the utilization of antenatal ultrasound to increase or to affect the development of the fetus in the uterus. We did observe that some patients utilize the reported among the antenatal ultrasounds to terminate pregnancy. That's been reported over the last couple of years. And then, of course, the paper, when we stressed that part, there was a lot of stress coming from this because it's not a very easy topic to talk about. And I will be very happy to hear about how is the legislation process in Mauritius to really understand the reality here. But of course, antenatal ultrasound, a lot of articles have been focusing that it should be integrated into routine prenatal care. In Brazil, as Dr. said, we have a law that states that at least 3 scans should be performed throughout the pregnancy. I think that's a major guideline among those Western countries. I'm not really sure if this is the same around here. But it's an important finding. And of course, some technical limitations and barriers associated to the execution of the technique has been really reported with the data. So I'm going to the end already. So several orofacial abnormalities they are potentially identified throughout with the gestational ultrasound, and we need to be very careful here because these abnormalities they are not commonly reported by the ultrasonographers, and by this, and that's where I'm going to end my remarks because that's where we are, and that's where Sue and I are going towards now. We are about to launch an international group of researchers. If there's anybody who's really interested in gynecology and particular obstetrics, feel free to talk to us. We are launching this year now a clinical panel of experts in order to, we're trying to prepare a guideline, a complementary guideline to support clinicians and ultrasonographers in terms of identifying how to identify these additional parameters. And that's where I'm going to end my remarks, because that's where we are. That's the real work that's before us. But of course, more research, even by the utilization of AI in gynecology and obstetrics is extremely important as well, because there are many processes of identification of malformations that can be facilitated by the use of AI. And of course, in our field, I'm a criminal, and I'm still working with people like with very different skills that I do have. But remember that as a physician, we have so many transferable skills that can be applied to many different medical measures. Thank you. I extend my
I just want to know about this data. Is it any geographical region from where this data is collected?
It's from all around the world.
All around the globe?
It's from all around the world, but mostly China.
I was looking at 614245 pregnancies, 680986 deliveries or fetuses. So find about 64,000.
So you mean by the ratio, you mean?
Yeah, the number of pregnancies and the number of fetuses or birth. And with an excess of almost 66,000 births. Is it that
I
level?
don't want to count, but the main reason is because there's one study. Okay, and this is a very interesting point because sometimes in systematic reviews we have a problem. One study takes the whole simple effect towards a specific direction. And we have in this study, one study included that it has more than 500,000 patients included from China. And then the whole magnitude of the numeric aspect is really shifted because of that particular study. But it's interesting because in China, we all know that there's a law that they're not allowed to have more than one kids. But then the law is not really, I don't know if that's your question.
No, actually the condition in China has not changed. The Xi Jinping is encouraging people to get married and have children and they are physically fit. So I'm just wondering, there's 64,000 more fetuses than the number of pregnancies. Does it indicate complete pregnancies?
We didn't prioritize inclusion of only single pregnancy. We did that only.
Thank you. Any other question?
Thank you. Congratulations for your keynote address. But one thing I want to know that this is the screen you are doing for the medical termination of the pregnancy or for the therapeutic point of view. For example, in the case of cardiac defect, the intrauterine correction they are doing, and I think they are doing correction intrauterine or not. That's my question.
Yeah, well, I think that they are already performing the extension of the parameters, the 12 parameters that the International Society of Gynecology and Obstetrics they prioritize. And I think cardiology is one of the fields that they're going to use those parameters. And no more question or there's one question.
Some random muscle abnormalities, but the earliest years we have detected cancer, and second, we have the random muscle abnormality was commonly Fuchs syndrome.
The second one,
Fuchs syndrome, right? It was detected at earliest period.
we did not detect that. No, that particular one we didn't. But the primary service didn't report that. We just reported, we collected data from those studies, from those abnormalities that were reported. But that one, no.
Another thing is question that can they be treated anti-diabetic?
They can.
Certain police can have exact treated anti-diabetic, but control muscle abnormality cannot be treated anti-diabetic.
Well, I don't know what's the current state of intrauterine surgery in Mauritius. In Brazil, it's very advanced, and it's funny because we're doing like a monopoly from our region. I'm from the second largest and potentially best university in the country, and she's from the best. So we're doing this, we call it India, unfortunately, which is like a debate. And in our centers, we have a huge team of specialists really trying to discover new technologies to perform timely interventions in the uterus. But it's, it's still very further ground for more research because, it's a microenvironment, can we say that? It's very difficult to adjust changes that need to be, to perform modifications in the utility.
Thank you, Dr. Israel.
I have two questions. Two questions. So a student needs to answer. Because this was the reviewer's comment, and I said, well, the reviewers are wrong. I'm not going to answer this. Well, we have to go at it. Why? So we show in our data many different, we decided to not perform a diagnostic test of accuracy, review, and meta-analysis, which means that we prioritize the narrative reporting of those performance metrics like sensitivity, specificity, and we decided to not collate these statistics in one final statistic in a first plot. Why we decided to not do that? Yes, Chef, repeat the question. We did not, okay. Instead of performing a meta-analysis of performance metrics, sensitivity, specificity, true positive value, blah, 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 we decided to not perform a final statistics for those metrics. Why was that? Otherwise, because people are more trouble than you. You can answer. I'm gonna go back to this very sad.
I know that the answer of asking for a clue has to do with time.
Yes, also. It has to do with Mauritius even. The different characteristics of Mauritius, people living here. Yes. Mauritius represents what? Diversity.
Multicultural.
I need a proper answer.
So, from the semester side, I would say that is it because of the limitation of heterogeneity that you mentioned yesterday?
And what type of heterogeneity we observe in our study? I didn't show the data for, of course, to make this question, this is a discussion, but what type of diversity we would face in our study? We started.
So this is what my analysis would be, that we didn't consider the operational expertise and we didn't consider the operational expertise and we didn't consider how we would standardize this across our healthcare systems to get the data. So there is where the heterogeneity comes in.
I'm going to give you the same choice. Well, heterogeneity is one of the main reasons because we included patients from all around the world, from China to Brazil, Brazil to Australia. That's one of the main reasons.
Did we standardize it?
We couldn't standardize the performance of the exam because it's a prospective study. A systematic review, we were looking backwards. We could not interfere in their analysis anymore because the studies were already published.
But then would this not be the publisher's bias then? Because we are looking at the data that we want.
But then tell me a way I could analyze the data without having a bias, a temporal bias. There's no, but and this is why it's important for you to, yeah. Well, I need two things. No. So do I have the list of people?
Can I suggest you hold your chocolate with the keton And
Where?
for the next session, because next speaker is waiting for presentation, let them think about it by the time. And then by the end of it, they should be able to answer.
No, you select a person to give it the
Okay, that's a better option. Select your girlfriend.
Oh, he said a man.
Choice.
Dr. Banerjee for helping us.
No, he said I'm already.
Yeah.
Thank you, Dr. Israel Jr. for that insightful and really engaging seminar. Our next keynote speaker is Dr. Shabani Devi Anna, Officer in Charge, 8th Unit, Ministry of Health and Wellness. She's a dedicated medical professional and public health advocate based here in Mauritius. She earned her Doctor of Medicine degree in Romania. She also completed a Master in Public Health at the University of Mauritius in 2018. She demonstrates leadership and expertise in managing public health initiatives and is committed to improving public health outcomes in Mauritius through her clinical expertise, leadership in health administration, and advocacy for effective healthcare policies. Please, ladies and gentlemen, a round of applause.
Good afternoon, everyone. First of all, I would like to take this opportunity to thank the organizing committee of SSR Medical College for giving me the chance to talk a bit about HIV, which is still a bit taboo in Mauritius, and to give you an idea what are the measures, the preventive measures that we are having in Mauritius, what the Ministry of Health is doing. So, we start by a brief recap of what is HIV. As you all know, it belongs to the HIV virus. It belongs to the Retroviridis family. Genus of viruses called lentivirus. And there are two types of HIV viruses: HIV-1 and HIV-2. HIV-1 being more frequent around the world, and it accounts for more than 90% of cases. And HIV-2 is less progressive and it's less common. The HIV virus, unfortunately, targets all the CD4 cells, which are present on various immune cells. And eventually, a person who is attacked by the virus, who doesn't take treatment, will eventually have a low immune system and can develop different kinds of cancers. Now let's have a look at the statistics around the world first. Since the first cases have been discovered, there have been 88 million people infected with the virus. And in 2023, there were around 40 million of people living with HIV. And only in 2023, 630 people have lost their lives due to AIDS-related causes. And there has been 1.3 million new cases. Unfortunately, 2/3 of the cases are in the African region. And it is sad to know that since the beginning of the epidemic, there have been 42 million people who have lost their lives to HIV. Any idea about the figures in Mauritius? Do you have an idea? People living with HIV? 4,000. It is estimated that there are 13,000 people living with HIV. This is the estimate from the UNAIDS. So we have detected 9,000 people living with HIV. You will see the ratio of male to female here. So it means that the difference is still living in Mauritius, but they don't know about the status. So maybe they are still spreading the virus around. That's an important reason why we have to get ourselves tested. And since 1987, the first case was detected, there have been around 2,000 deaths, 2,151. The concentrated among key populations. What are key populations? It's those groups of people who are more at risk. And among them we have people who inject drugs, 21% prevalence, female sex worker, 15%, MSM men who have sex with men, 17%, transgender people, 28%, and user inmates, 12.7%. Otherwise, the estimated prevalence overall is 1.5%. You will note that in only 1 year, we get around between 350 to 400 cases each year. Here you will see the yearly number of cases that are diagnosed. Since 2001, we have more than from 2001, and you will see that it has increased in 2005. And then suddenly there's a drop. What happened here? There was the HIV/AIDS Act, which was enacted in 2006. So we have introduced the needle exchange programs for drug injectors and methadone substitution therapy. So this has worked, and you see that there's a decrease in the number of cases, and now it has more or less stabilized. When we talk about HIV, people still think that it's more concerned about people who inject drugs or maybe sex workers. But this graph will show you that it's not the case anymore. So the red line is for the injecting drug users. You will see that there's a decline in cases among them, while through heterogeneous sex, you will see that the number of cases are increasing. And now in 2023, you will see that 61%. And 28% among drug injectors. Initially, when the epidemic just started in Mauritius, there were much more men than women, but now there's a feminization of HIV. So there's more and more women who are getting infected. And you will see the major causes are due to cultural norms, or maybe the balance of power, which make it difficult for certain women to negotiate safe sex. And also the economic dependence and fear of violence disempower women. The age group which is more commonly affected with HIV is the young generation, 25 to 29, we have 30 to 34. And in this one, with this chart, you will see the cumulative total number of cases diagnosed till now. And these were the ages at diagnosis. You will see that 25 to 29 have the most important number of cases diagnosed. And this chart shows the number of deaths. I think you all know that nowadays, with the treatment that we have, the more advanced treatment, we're not supposed to have people dying with HIV. They can live a normal life, and they don't even transmit the virus if their viral load is undetectable. They can even conceive and have children who are not infected with the virus. But it's unfortunate to see that due to stigma, we have patients who prefer to die rather than coming to our services to get themselves treated, even if they know that afterwards they won't spread the virus. And we still have people who are dying every year. As I mentioned earlier, the age group mostly affected are the young groups, but we do have cases, newly diagnosed cases at 70 years, 80 years, and the persons have been infected through sex. So sometimes we think that maybe the older generation, they don't talk about it, so they are not having unsafe sexual relationships. So on our side, it's important to sensitize everyone. And this graph will show you where we usually, at the age limit, where do we conduct testing. The VCT is voluntary counseling and testing. Blood donors, fortunately, the screen for HIV. And we got, for the year 2023, 17 new cases from blood donors. Prison inmates, which is done routinely there, we have HIV testing. Hospital provider initiated testing and counseling. We got 126 cases, the most cases we get from hospitals. That's why we have introduced ward testing as well now. So randomly we test patients for admitted wards. TB, I put it here because usually we do get cases from TB. It's really closely connected to HIV. But fortunately, we didn't get any case last year. Harm reduction, addictology, antenatal care, we do get new cases. Private patients, this one is from CHC, this one is postmortem unit, and Roderick 8 Secretariat. Now let's talk about the HIV prevention services. In Mauritius, we are fortunate that the government is very committed to eliminating HIV in Mauritius. So there was a new action plan which was implemented last year, which aimed to address all the gaps, to eliminate the gaps in the HIV cascade. And also there's the high-level drugs and HIV council under the Prime Minister's office, which also talks about harm reduction measures and HIV prevention measures that are being implemented and what new can be done. And finally, we have a multi-sectoral coordination committee, which has been set up by the Ministry of Health and Wellness, which brings together all the line ministries. We have Ministry of Gender, Ministry of Education, where at each level we see what can be done to eliminate HIV. For our services at the AIDS unit now, there are 8 daycare centres for the immunocompromised, which is all around the island, so that people can have easy access to the services. And we also have 2 one-stop shops. One-stop shops so that people who are infected with HIV can have all the services under one roof. And here we have general consultation, blood investigation, HIV treatment, methadone, dental services, immunization services, hepatitis C treatment, which is now available. And the patients get treated for after 3 months of treatment, they are fine. Family planning services, dental care services, other prevention services, and psychological support. I don't know if you're aware about the NGO pills, who's actively also participating in the fight of in HIV. Recently, it was 2 years back, the Ministry of Health, in collaboration with NGO pills, have inaugurated a center so that people who feel a bit stigmatized, who don't want to go in the government hospitals, they can feel free to go to the NGOs to have the same services. So once a week, our doctors from the Ministry of Health, they go there to provide all the services that I'm going to mention. So here's an overview of all the strategies, the prevention strategies that we have in Mauritius. As I mentioned, we have the National Action Plan, and 4 of the 5 strategic objectives, they talk about the prevention. The strategic objective 1 is to reduce by at least 25% new HIV infections. The second one is to reduce by at least 50% the number of AIDS-related deaths. And the next one is to reduce the mother-to-child transmission to 0. And finally, to reduce structural and other barriers, for example, laws that are criminalizing which prevent certain groups of people to access our services. And then we do have a prevention package, which includes awareness sessions, which are done in schools and even in workplaces and several other places in Mauritius, condom and lubricant programs, pre-exposure and post-exposure prophylaxis, prevention of mother-to-child transmission of HIV, harm reduction measures, and also treatment as prevention. And finally, the government has a strong political will to eliminate HIV. In Mauritius, we do apply the combination HIV prevention, which is a combination of rights, evidence, and community-based programs that include biomedical, behavioral, and structural interventions to prevent HIV. So there is not a single prevention method, which is a combination. For example, if someone, for example, a man having sex with a homosexual guy who wants to have certain services, but he feels that the law is not protecting him, even though the service is available, but person won't have access to those services. So that's why we have to ensure that everything is in the favor of the person, so that he's encouraged to have access to services. So for behavioral interventions, we have the ABCD. I don't know if you're all aware about it. It's abstinence, be mutually faithful, correct, consistent condom use. D is don't do drugs, don't share needles. And E is education and early detection. We often do, the main thing that we do is counseling on risk reduction. And we have peer education programs. So we have peer educators who are like role models. They may be ex-high intravenous drug users who have successfully followed the treatment and they are now undetected. So they act as role models for others. They are the ones who encourage other drug users to get into the system, to start their treatment, and become undetectable like themselves. And we have social marketing campaigns to promote drug use. And at the age limit, what we do regularly is mass media campaigns. We do regular workshops with different stakeholders, continuous medical education and continuous nursing education as well. And recently, the AIDS unit and harm reduction unit have worked together to build up a common prevention program where we talk both about HIV and drugs. And you will know that in 2023, there were 2,200 sensitization sessions, and we have reached around 25,000 persons. We also attend schools and tertiary institutions, but unfortunately, due to the fact that we need parental consent for testing, we can't be testing on young people below 18 years old. But it has started in tertiary institutions for those above 18 who can give their own consent. And now we have biomedical interventions. We have male and female condom. The male condom is more commonly used than the female condom. And we know that they protect against both sexually transmitted infections as well as pregnancy. Recently, the ministry has been able to install condom vending machines. I don't know if you've heard about it. It's called condom vending machines, but it's actually dispensers of condoms, free of charge. So it's free. This has been done to promote easy access to condoms to everyone. And these are the locations of the condom vending machines. We have been able to get 25 machines, and we have ordered further 25 machines which will be installed in other regions. Now we talk about HIV testing, which is also a preventive measure. Why? Because someone who knows his status or her status will try to protect others, and so this will be like a preventive measure. At the age limit, we usually do voluntary counseling and testing, as I said earlier, at the casualty level, in wards in hospitals. We do it also at the Banner Center in collaboration with NGOs. We also have a caravan which goes daily around the island to do counseling and testing. Now, all the women how to do the HIV test so that when they can start the improvement if they are positive. We do awareness and testing sessions outside of work, tertiary institutions, public places like beaches and commercial centers, even in deprived areas. And we do outreach programs. So we go towards the public, and we have to target the high-risk groups, as I mentioned, the high-risk groups. And what we do counseling, we do testing, condom distribution, and as well as we do distribution. VCT among prison inmates at entry point, so when they have just been admitted to prison, we have to do a test, and sometimes we do pre-testing as well. And here we will do a bit about the figures in Mauritius for last year. In all, there have been around 98,000 tests ELISA and 38,000 rapid tests which have been done. And for the caravan testing, around 7,500 persons were reached through awareness session, and among them, not all get tested. You cannot force someone to get tested. It's according to the person. If they want to get tested, then you cannot force anyone. And out of those who got tested, we got 37 cases. 37 cases. And also in the accident and emergency department, there were around 9,000 tests done, and 15 were positive. And in prison, there were 66 who were found to be positive. The HIV self-test, I don't know if you heard about the HIV and AIDS Amendment Act. There has been changes in the law so that now someone who wants to get tested can do this test by himself. And now the National AIDS Program is developing the testing guidelines so that people know how to conduct the tests. We are still working on it. Antiretroviral treatment is provided free of charge in Mauritius. And why is it important? Everyone gets treated. You cannot be there's no cure actually for HIV, but if you take your medicines regularly, your viral load will get undetectable, and this reduces the risk of transmission. U is equal to U, undetectable means untransmissible. And you know that in Mauritius, out of those living, so there were around 9,000 people detected, 2,000 dead, so this is the number of people living with HIV who are living in Mauritius. But not all of them are on treatment. Some of them, due to stigma, they don't want people to see them in our daycare centers, they prefer not to follow any treatment. And that's why, unfortunately, we get them at the AIDS stage finally. Or either they die or it's too late to do anything for them. The prevention of mother-to-child transmission of HIV. There are 4 pillars. First is primary prevention to prevent HIV. The second is if you have a pregnant woman who doesn't want to get pregnant, you have family planning which is done. You have also counseling about safe sex and dual protection, so it means using condom and using also hormonal treatment. And finally, the third pillar we have prevention of HIV transmission from a woman living with HIV to an infant. And this one, in Mauritius, we provide free treatment to all pregnant women who are detected positive. And also, depending on the viral load, we decide whether we should deliver normally or to receive cesarean section to reduce the risk of transmission. The baby also is put on prophylaxis for 1 month to further decrease the risk of transmission. And breastfeeding is contraindicated in Mauritius, so we provide formula milk free of charge to all women living with HIV who have delivered. And finally, there's a follow-up of the pregnant person, the women of the delivery, the baby, and the whole family. On average, there's approximately 10,000 pregnant women who are tested for HIV, and we get around 100 to 110 positive cases, among which 60% are usually, more or less 60% are usually new case, and 40% are new cases. Have you heard about post-exposure prophylaxis? We do provide post-exposure prophylaxis both at the age limit and at casualty level in Mauritius. And it's important to have the post-exposure prophylaxis within 72 hours, otherwise it's too late, you cannot do anything. And who usually take post-exposure prophylaxis? Those who are at risk, for example, in case of sexual assault, exposure in healthcare professionals, during surgery or delivery, during sexual intercourse, or maybe accidental exposure to non-steroid needles or injecting equipment. Every year we get around 250 to 300 persons who get access to PrEP as per protocol. Have you heard about pre-exposure prophylaxis? This is a bit new. So what's pre-exposure prophylaxis? So it's a medicine given to those who are at high risk. Usually, you have the sex workers, you have people who have partners who are HIV positive but they are not positive. And also we got people who are not using condom regularly. This person will take one medicine, one tablet a day, and they can have sexual relationship with someone who's positive and they won't contract the virus. It is up to 99% effective through sexual intercourse and 74% effective through intravenous drug use. The harm reduction unit is usually a separate unit, but we still talk about it anyway. So we have the needle and syringe exchange program and methadone substitution therapy. Finally, we have the structural interventions, which are laws to protect people living with HIV or those who are at risk. As I mentioned, we have the HIV and AIDS Act, which safeguards the rights of people living with HIV. So we don't have the right to stigmatize people who are infected or affected by HIV. If someone attends a healthcare facility and feels that he or she faces discrimination, so there is a penalty not exceeding 50,000 or imprisonment not exceeding 12 months. And the Act was amended to introduce self-test and also to introduce paraphernalia, which are injecting materials, so that people don't share these injecting materials to contract HIV and hepatitis C. There's also the DUAP, Drug User Administrative Panel, which is new. It has been implemented this year. So if you see someone with drug on him for personal consumption, he's not prosecuted anymore. So he can have a rehabilitation. To conclude, as I mentioned, we don't have any cure for HIV, but if we follow the prevention strategies that we have, we can have HIV can become a chronic infection, and the person can live normally, and we have to use combination HIV prevention approaches so that we can achieve the sustainable development goals to end AIDS by 2030. Any question?
Thank you, Dr. Shivani, for your excellent talk. I must congratulate you. I have a few questions for you, then I will open it for the audience. Like, I am a pharmacologist, so I have to know about the drugs you are using in Mauritius for pre-exposure prophylaxis of HIV and post-exposure as well. And also I have to know about the 211, the therapy that is followed over here. Can you explain? Correct. Yes, thank you.
So for your first question, according to our protocol, the first line of treatment, we usually use dolutegravir and Truvada. Dolutegravir is an integrase inhibitor, and Truvada is an NMRTI. Then we use that reverse transcriptase inhibitor. This is the first line. So for PEM, we use dolutegravir 1 tablet a day and Truvada 1 tablet a day. And for the pre-exposure prophylaxis, as you mentioned correctly, there are 2 ways of taking it. Usually for women, you have to take it every day. It's not studied, the 211 is not studied in women. So if a person is HIV positive, the partner will have to take, the partner if she's a female, she will have to take it every day. The Truvada or the Descovy. You have 2 drugs, either or. You take it every day. Otherwise, Dr. mentioned 211. I don't know if you know about it. 211 is pre-exposure prophylaxis, which is event-based. So this one is studied only in homosexuals. It's not among those who have. It's not used among women. It has been studied among homosexuals. So if someone knows that he or she will be at risk, maybe in not all the time, maybe in an event, for example, in the weekend. If he's going to be at risk on Saturday, so 24 hours, 2 to 24 hours before, he has to take 2 tablets of Truvada or Descovy. And then on the day of the event, you have to take 1 tablet, and then 2 tablets 2 days a day. That's why it's called 211. So if someone is going to have safe sex, for example, on Saturday, on Friday, so 2 to 24 hours before the event, he has to take 2 tablets of Truvada. Then on the day of the event, Saturday, he takes 1. Sunday and Monday he takes 1 and 1. So he's covered. He's have to take it every week.
Thank you so much. Anybody else have any questions?
Congratulations, Dr. Swami, for your wonderful presentation. I have 2 questions for you. So, first question is, as you know, tuberculosis is the most opportunistic infection among the HIV patients. So, in many countries, including India, we have bi-directional screening. That means all the HIV patients are being tested against TB, and all the tuberculosis patients are being tested against HIV. So, though you mentioned in the preventive studies that there is collaboration for the TB HIV program, but can you tell me whether the bi-directional screening is being effective in enforced in Mauritius?
Yes, actually, what we have noted is that all the patients who are admitted at the TB unit, they all screen for HIV. And also at the HIV unit, we do screen on and off, but not always. Now we are working on a prophylaxis for TB for our patients, but we're still working on a protocol for that. So maybe depending on the stage in which the patient is, we will be working on that. But otherwise, in the TB department, they always screen for HIV.
My another question is rather a query regarding the policy recommendation. As you mentioned, the breastfeeding is contraindicated in Mauritius. Now, all over the globe, the evidence suggests that if we withhold the breastfeeding, rather than causing benefit, it can cause harm. In the sense, as we know, the prevalence of malnutrition is very high, especially in Eastern Africa, and Mauritius is in Africa. So, my suggestion, like you are an officer in charge working in that unit. So, if we withhold breastfeeding, there can be the chances of malnutrition very high, and as you know, there is a vicious cycle for malnutrition and infection. So, rather than intended for benefit, it can further put them for the further risk and aggravating risk, including all risks, including HIV. So, if anything can be suggested from your side.
Yes, but I think, thank you for your question. But I think that we have to, unfortunately, not all pregnant women are undetectable. So there is a risk that through breastfeeding, there is a risk of transmission to the child. You mentioned correctly that in Africa, usually, due to poverty, they don't have access to clean water. So it's more dangerous for them to have formula milk or liver milk rather than breast milk. So that's why in Africa they do breastfeed. But in Mauritius, I think it's something we can debate about. Maybe some women who are undetectable eventually they may be allowed to breastfeed. But for the time being, it's not always the case. We have very few women who are undetectable. So to minimize the risk, and maybe the other argument to medicine after delivery, even if they are undetectable before. So there's a slight risk. That's why it's complicated. But I think we can work on it.
We will take one last question. Last question from Dr. Forrest to answer your question.
Can I I'm sorry for taking the time. Thank you for your presentation. I have a couple of questions. I merge both the questions. Two-part question. You mentioned that you randomly test in the hospital patients. How far is it ethically and legally right? Do you have a policy on that? And what if a patient actually denies, objects, or maybe after you have tested, he raises a query as to how you tested him randomly? And I'll finish the second one. When you voluntarily test an individual and he is positive, what's your policy on testing the spouse or informing the spouse and confidentiality of the results? Thank you.
So the first question is, in hospitals, when we do testing, we always take the consent. Unfortunately, I think when people are sick, they are allowed to do all the tests not necessary, so we have the chance that they are less likely to refuse. So if we do program counseling, we usually have
But they are informed that
they are informed, they are always informed, otherwise they get screwed because of the HIV AIDS Act. And for the confidentiality, according to the HIV and AIDS Act, even the spouse, they do not have to tell their spouse about it. And they want it to be confidential, we are not allowed to tell the spouse.
as a policymaker, don't you think that might actually increase the spread of the infection or just transmitting?
For the time being,
spouse?
just encourage the person. We have our psychologist also who sees the person, who have encouraged to want them to disclose to the partner. But we don't disclose. But you are also right, you mentioned spread the infection. This is also important that we have to see.
Thanks so much.
Last one more question to take to Dr. Bhatt. It is quite interesting and this is the last question.
Dr. Anna, congratulations for your excellent presentation. You highlighted all the events of HIV and the people living with HIV. And my query is that I know that Mauritius is health and education is free. Your program, government policy is to eliminate this HIV. Do you think this is a more ambitious program? Because I remember WHO also during 1960 they planned eradication of malaria eradication project. Finally, they know that it is not possible to eradicate. That's why now they are the eradicate. In spite of eradication, there's the control program, malaria control program. Do you think that the government can eliminate this HIV from this Paradise Island?
It's very challenging, but it's not impossible. But ideally, look at HIV patients. The main problem is the taboo. People don't get tested. Even if you take our caravan and go in front of them, they will think, what people will think if I go inside the caravan, they will think that I have risky behavior. So they prefer not to get tested. If I may ask, how many of you have done HIV tests? It's not bad. Usually when I ask this question, it's just one person who says this kind of one. But we are all concerned about it.
For example, Russia, they go around the certain information for health workers. Frequently they have to test HIV, then only they allow to enter the hospital. That's a strong rule and regulation for not only surgeon, all the health workers.
But here to the HIV and AIDS Act, we cannot force anyone. Even for employment, that's legal.
Let us carry this discussion to the team. So we'll end here.
Thank you very much for your
Thank you, Dr. Banana, for sharing your expertise with us. Your seminar was not only informative, but also a very big eye-opener on HIV on this island. Now, I would like to call upon Dr. Nikhil Nanda to please present our keynote speakers with some certificates. Firstly, Dr. Nikhil Nanda, please, and Dr. and Dr. Banana. for